A very good evening, colleagues. The time is just gone a little after 6:30 p.m. CAT or SAST. Very warm welcome to another session of the Intellectus Campus, hosted SADC CPE sessions. Today's topic is asthma management, delivered by Dr. Jacke Stone. Before we proceed, allow me to run through a couple of housekeeping requirements. For starters, my name is Zobake Mwatse. I serve as the General Manager of Intellectus Campus, your host this evening. We are a training and skills development college with as 8 campuses across 5 countries. As part of the theme for health and social sciences, we host these CPD sessions once weekly every Wednesday. Colleagues, if we can first request as part of our housekeeping, please ensure that your mics are muted for the duration of the session. The session is an interactive session. However, if you wish to make a comment or question, please raise your hand and a member of the Intellectus team will recognize you to enable you to make your submission. Secondly, if you refer to the chat, there are several links in the chat. The primary or most important link is the link for the attendance register. Please complete your attendance details per the attendance register, per the link that is in the chat. Should you not complete the details on the link or per the link, we will not be able to capture your details accordingly, and we won't be able to circulate the certificate, the CPD accredited certificate accordingly. Colleagues, as indicated, today's session is titled Asthma Management. Our keynote speaker for the day or for the evening is Dr. Jacke Stone. Dr. Jacke Stone carries an MBChB, BSc MED Hons, MRCP, FRACGP, Aviation Medicine, FACAsM, is a Zimbabwean primary care physician who grew up in Zimbabwe. She graduated from the University of Cape Town cum laude in 1999. She went on to get a Medical Research Council scholarship to do an honors degree in Medical Biochemistry, which she completed in 1992. From there, she went on to the UK and worked in the Infection and Immunity Department at St. Bartholomew's Hospital in London and wrote her MRCP in 1996. Her main interest was in HIV, and during this time, she was involved with the introduction of combination antiviral therapy as the cornerstone of successful treatment and prevention of the HIV pandemic. She then moved to the Middle East and worked in the airline industry for a period of 12 years. In 2003, she was part of the airline's SARS Co task force. She completed a diploma in Aviation Medicine in 2008 from the King's College in London. And this, she feels, taught her a great deal about risk-benefit assessment, hypoxia, infectious disease treatment, and prevention and vaccination. The airline employed 135 nationalities and 20,000 flight crew, all of whom required protection. In 2008, she moved to Australia and completed her FRACGP in 2012. She also became an inaugural member of the Australian College of Aerospace Medicine in 2012. Both in the Middle East and Australia, she developed an interest in integrative medicine. She returned to Zimbabwe in 2015 for personal reasons and is now an executive committee of the Zimbabwean COVID Frontline Clinicians Society, who advocate for saving lives through early, safe, effective, affordable combination therapy. She has used Professor Thomas Borody's combination therapy and has worked with Professor Borody and Dr. Sabine Hassan in California, looking at early outpatient care for SARS Co V2. She feels that the main lesson we need to learn from the pandemic is that African-trained doctors should believe in themselves and their practical knowledge together with experience, and can lead the way in early treatment of SARS CoV2. We have some of the best statistics in the world, and we should be proud that we have the ability to adapt and innovate to keep up with these rapidly changing times. A quote from Dr. Jacke Stone. A very good evening, Dr. Jackie.
Thank you very much for that introduction, Obi. I need whoever's hosting to allow me to share my screen.
Dr. J, you are able to hold, so share screen, you're a co-host on both devices.
Okay. I'm changing it to all participants. Okay, can you see the share?
Confirmed, yes.
Perfect. Okay, welcome everyone to another section of Intellectus Campus. I want to go into asthma on back to basics, because I do really believe that it's become overcomplicated. I'd also like to bring in an integrative angle, because Avicare's motto is innovative and integrative solutions for health and caring for Africa. So I'm just going to move on. Sorry, I'm struggling to get this to move. Here we go. So let's start looking at Africa, and let's start looking at an overview of early life factors that increase or decrease the risk of asthma development. So I think we've all seen that in an urban environment, in children who have smoke exposure and adults, pollution, excess early weight gain in childhood, prematurity, and problems with the microbiome, we see an increased incidence of asthma. Now, it does run in families. My daughter is asthmatic, and it does run in our family as well. But it's a genetic and an environmental disease. One of the things that we need to be aware of is the importance of vitamin D supplementation. Can you hear me?
Yes, we can. You had both mics on, so I muted one of them.
Okay. So the importance of vitamin D supplementation, which reduces the risk of asthma. And I've had a number of asthmatics who have gone, especially children, in winter, where we supplement them with vitamin D and they get a lot better. There have been over 7 randomized controlled trials and in children and adults, and they all show a reduced risk of exacerbations. They show a reduced need for systemic corticosteroids, and they show a decreased risk of hospitalization. So one of the very simple things that you should do for all your asthmatics is check their vitamin D levels and get them up to above 50 nanograms per ml if you have an asthmatic who is vitamin D deficient. If we look at vitamin D supplementation and acute respiratory tract infections, if we look at the influenza vaccine, the number needed to treat in adults is 40, whereas if we get their vitamin D levels up, the number needed to treat to prevent one acute respiratory tract infection, which is often a trigger for asthma, is 33. So I'm going to go right back to basics. Asthma is a disease that involves constriction of the bronchi, also known as bronchoconstriction, and inflammation. And the medication needs to be delivered as efficiently as possible to the airway. Bronchodilators are divided into short-acting beta agonists called SABA and long-acting beta agonists called. Some drugs, and one in particular, formoterol, are both short and long-acting. And one of the things I would like to discuss as well is a medication that's just landed into Zimbabwe and been cleared called Avacort, which can be used as a reliever and as a preventer. A lot of doctors forget about inflammation, and inflammation is very important in asthma. If you only treat by dilating the airway, the moment the dilation wears off, the inflammation will then result in more bronchoconstriction. And delivery devices are critical. So if we look at these pictures, you can see that a normal airway has a muscle-lined, fairly thin wall and no mucus in it. Whereas an asthmatic airway will have muscle that has constricted, thereby narrowing the airway, but the airway also is full of mucus. So people with asthma, at times when this happens, it is very hard to breathe. And one of the things that's very difficult is to breathe out. So air trapping occurs in the lungs, and you will see that an asthmatic who is wheezing will often be breathing very shallowly, but it's because their lungs are actually full of air. The other thing about asthma is it comes and goes. And so sometimes the patient will be able to breathe perfectly well, but if triggered, they will have symptoms. So a sort of picture of the difference between a normal airway and an asthmatic airway is shown here. The bronchoconstriction shows that the airway is narrowed, and the inflammation shows that the airway is full of mucus. And those of you who deal a lot with asthma will see that people will complain of coughing up these white plugs, which is the inflammation. So how do you open a constricted airway fast? And the answer is you give a beta agonist. And the most commonly known one is salbutamol, also known as Ventolin. But formoterol, which is in Symbicort and Avacort, works as quickly as salbutamol. Salbutamol wears off very quickly, within 4 hours, whereas formoterol can last 8 to 12 hours. And I will go into that a bit later. So short-acting, the one we all know, salbutamol. Long-acting, salmeterol. That is also known by many as Seretide. And the short and long-acting is formoterol, which is in Symbicort and in Avacort. So if we compare them, salbutamol will work within 5 to 15 minutes. It can be delivered with both a metered dose inhaler and by nebulizer. Formoterol is not available in a nebulized form. And the maximum improvement in pulmonary function usually occurs 60 to 90 minutes after treatment. And for athletes who get bronchoconstriction, it's quite important for them to understand that they don't just take their puffer before they run on the field. They need to take it an hour before. And the bronchodilator activity will persist for 3 to 6 hours, on average 4 hours. Formoterol, which is available in a number of devices, bronchodilation occurs at 3 minutes and continues for 12 to 14 hours. So with long-acting beta agonists, the fact that they are lipophilic, in other words, they dissolve in fat, that it ensures that they not only have a rapid bronchodilating activity, but they also remain in the bronchus for longer. Salbutamol is hydrophilic, which means it likes water, and it also means that it is cleared very quickly. So if we look at, for example, a combination of serotype or of salmeterol with a steroid, we will see an onset of action only at 30 minutes. Whereas if we're looking at Symbicort, Avacort, which contains formoterol, as well as inhaled steroids, we will see an effect at 3 minutes. The difference is they both will last for 12 hours, but salmeterol does not work for 30 minutes. And in someone who's having an asthma attack, you have to be fairly careful if you are using salmeterol. It is a very good preventer, but it is not a reliever. So getting back to it, most people will talk about relievers and preventers, and short-acting beta agonists are what we would refer to as a reliever. Now, a lot of people say, why do we not treat with short-acting beta agonists alone? We know that, and very commonly, patients treat themselves. So they go to the pharmacy and they pick up a Ventolin or a salbutamol inhaler. And in the days where we thought that asthma was only bronchoconstriction, then it makes sense to use inhaled short-acting beta agonists only. It is low cost. You have rapid relief of symptoms. However, tolerance does develop if you use it for 1 to 2 weeks, and then it ceases to be effective. So it's very important to add a beta agonist to inhaled corticosteroids. So the preventers reduce inflammation and they reduce mucus. Inhaled corticosteroids are now treating inflammation. So we're moving away from dilating the bronchus into getting rid of the inflammation. And the inflammation very often is the trigger for the bronchoconstriction. So it's really important that we used inhaled corticosteroids where it's appropriate. They are the FDA indicated treatment of choice in preventing asthma exacerbations. And persistent asthma is classified by symptoms more than 2 days a week, more than 3 nighttime awakenings per month, or the need to use salbutamol more than twice a week, or any limitation of normal activity due to asthma. Now, particularly in children, it is so important that they can live a normal life, get out into the sun, exercise normally, and it has been well shown that if we use a combination of a long-acting beta agonist with inhaled corticosteroids, these children can complete a normal life. Now, one of the questions that was asked when I presented this recently at the Zimbabwe Medical Association was, surely inhaled corticosteroids will lead to bone density problems and will lead to problems with growth. And a study was done looking exactly at this. And in fact, children on inhaled corticosteroids grow better because they get more vitamin D and they exercise more. And they actually also have greater bone density because they are able to exercise. And one of the things I think it's important to understand is that if you give oral corticosteroids and you give a 40 milligram dose, you are giving 8 times what that child will produce or that adult will produce in a day from their own adrenal glands. Whereas if you're giving a 50 microgram dose of fluticasone and only 10% is absorbed, you are giving so little steroid that given that your adrenals are making 5 milligrams or 5,000 micrograms a day, you would have to use an inhaler for 4 years to get the same amount of steroid into the system as you will do with 1 day of oral corticosteroids. So if you want to avoid oral corticosteroids in your patient, it's a good idea to have them on an inhaled corticosteroid if you want that person to have a normal life. And the ideal is that there is no need for salbutamol at all. So let's start looking at the options. Fluticasone, otherwise known as Flixitide, beclomethasone, otherwise known as Beclate here, and budesonide, which is known as Palmicourt. Now, fluticasone is at least as effective as beclomethasone and as budesonide. And it's effective at half the daily dose of the others. It also causes less oral thrush. So we would certainly recommend fluticasone as the agent of choice. However, we will say that beclomethasone is much more affordable. Hopefully, Avacort coming onto the market, which is a combination of fluticasone and formoterol, will be a lot more affordable than Symbicort and Flixitide. So why would you not treat with salbutamol and intermittent prednisolone in a flare-up? It is certainly the most affordable option. And in Africa, we have to take cognizance of the fact that not all of our patients can afford some of the more expensive drugs. But if we look at using fluticasone, less than 20% is absorbed, and you will use 1,000th of the dose of a dose of oral steroid. And our goal is to avoid any exacerbations as far as possible. So what are the goals of asthma treatment? Few asthma symptoms, ideally in a child, no asthma symptoms, no sleep disturbance, no exercise limitation. We want to maintain normal lung function. We do not want flare-ups that require hospitalization, particularly in patients that live in remote areas where it's going to take them an hour and a half to get to a clinic that may not actually even have a nebulizer or have power to run it. Prevention of asthma deaths is really important. Far too many people in Africa actually die of asthma compared to the West. And we also want to minimize medication side effects. Oral corticosteroids. I have had one of my children on oral corticosteroids for asthma, and it causes hyperactivity, it causes insomnia, and it can cause all sorts of interesting behavioral changes as well. So apart from the fact that oral corticosteroids will suppress the adrenals after 3 to 5 days, we also don't want the side effects in terms of the child can actually end up with all sorts of problems. They may not be awake because their lungs are not working, but they're awake because of side effects of the drugs. And we need to also remember that patients with minimal symptoms can still have severe life-threatening exacerbations. And one of our pulmonologists presented on this the other day. Just because a patient you've said has mild intermittent symptoms doesn't mean they can't have a severe asthma attack. So the Global Initiative for Asthma has recently issued new guidelines, and I prefer, well, both tracks are fine. The second track, step one, is to take a short-acting beta agonist and take an inhaled corticosteroid whenever the short-acting beta agonist is taken, so that you don't go into another attack 3 to 6 hours later. Now, the ideal for that is the combination of formoterol and fluticasone, which is Symbicort or Avacort. Step two, if that's not controlling it, you would use a low dose of maintenance inhaled corticosteroids on their own. If that's not working, you use low dose maintenance inhaled corticosteroids and a long-acting beta agonist, which could be either salmeterol or formoterol. And then it goes up to using medium to high dose maintenance inhaled corticosteroids and LABA. And if you're still not controlling at that point, it may be worth referring and starting to add on some of the other agents. So I'm not the classification of asthma severity. Mild asthma is controlled using as needed inhaled corticosteroids and formoterol, or low dose inhaled corticosteroids with as needed salbutamol. Moderate should be controlled with low or medium doses of regular inhaled corticosteroids and a long-acting beta agonist. And severe asthma requires high-dose inhaled corticosteroids and long-acting beta agonists to prevent it from becoming uncontrollable. So one of the things we need to do is understand inhaled devices. Now, the very first inhaled device was a metered dose inhaler, which had a propellant with salbutamol added to it. After the aerosolized drug is delivered, the airborne particles are largely deposited in the mouth, in the oropharynx, and in the airways, but a large proportion of the drug, particularly in children, is swallowed and is then absorbed through the gastrointestinal mucosa and then has to go through the liver before it actually gets to the lung. And in fact, using a metered dose inhaler, only about 20% of the aerosolized drug is delivered into the airway. So this is a demonstration of using a metered dose inhaler alone. And as you can see, a lot of the drug is ending up in the upper airway and in the stomach and in the trachea. Whereas if you add a spacer to a metered dose inhaler, you will see that the majority of the medication will end up in the lungs. So I really do encourage you that if your patient is using a metered dose inhaler, which will usually be Ventolin or salbutamol, it's a very good idea to add a spacer. One of the other things to note about a spacer is if you are saying to the patient, take 2 puffs, they must do 1 puff, breathe 4 times, second puff, breathe 4 times. Otherwise, it's not as effective. So in 1956, we got the first pressurized metered dose inhaler. However, people were concerned about propellants, as they are concerned about spray deodorants and all the rest of the environmentally unfriendly agents. So dry powdered inhalers came in. And in 1987, the first multi-dose dry powder inhaler was budesonide or Palmicourt. So global warming goes back to 1987, the concerns about it. And that was one of the reasons why the dry powdered inhalers entered the market. By 2023, to be perfectly honest, I think there's total confusion. There are so many devices, and there are basically 4 groups of what can go into the device, which is the beta agonists, short and long acting, inhaled corticosteroids, combination treatment, and then there's the muscarinic antagonists, which I very seldom use personally because I think we can generally control it with beta agonists and inhaled corticosteroids if they're used correctly. So again, the confusion. One of the most important things to understand is that if you fail to use the device correctly, you will have poor control. And while inhaled drugs are the mainstay of treatment for lung diseases, both in asthma and in chronic obstructive pulmonary disease or emphysema, failure to use the inhaled device correctly leads to a poorly controlled status. And if we actually look at how, the videos on how to use each device, they are all very different. Now, I'm not sure if this will play, but if it does, it will give you an idea of this. I need to skip the ads. Can you hear? If you can't, it's fine because it's got subtitles.
No, I can hear.
It's not playing.
Dr. Jackie?
I know you
Maybe
can't hear the audio, but can you see the patient using the inhaler like perfume?
Yes.
We really do need to know that our patients are using their device correctly. And
Dr.
if you
J.
can click on the link at a later stage, you will see that patients often do not know how to use the device. So drug delivery to the lung, the patient must have the cognitive ability, and it's remarkable how many emphysema patients with dementia are prescribed a device that they cannot use because they don't understand it and they don't have the manual dexterity. But one of the other things that's very, very important to understand is that many of these devices require significant inflow. And if you've ever used an AccuHaler or a turbohaler, you have to generate 30 to 60 liters a minute to get the powder to enter the lungs. So to adequately inform specific inhalation maneuvers with a given aerosol delivery device, you can't actually be in the middle of an asthma attack because you won't be able to generate the inflow for it to work. So training from a doctor or another healthcare provider is essential for learning to use the device you use correctly. Now, interestingly, 68% of patients don't know how to use their device, and 67%, so 2/3 in each case, of nurses, doctors, and respiratory therapists are also unable to adequately describe or perform the critical steps of inhaler use. So there is a need for better education to train patients, and Intellectus Campus will be next year, hopefully running a certificate for nurses to become certified in training in asthma. So if we look at 30 to 60 liters per minute airflow required to activate the inhaler, if somebody, and I'm sure we've all seen emphysema patients who look like this, there is no way this man is going to be able to use a serotide AccuHaler. He just will not be able to generate the airflow. There are videos that you can find on using an AccuHaler. I've used one, and you really have to be able to fill your lungs, to completely empty and fill your lungs. And when you're in the middle of an attack, that is not going to happen. So if you have the facilities for spirometry, and most of us in Africa don't. You can do a peak inspiratory airflow, but we already know that 65% of emphysema patients have an airflow of less than 60 liters per minute, and 11% have an airflow of less than 30 liters per minute, which means there is absolutely no point in prescribing an AccuHaler or a turbohaler. We also know that a fifth of patients use the MDI too fast and the medication is not delivered to where it needs to go. So again, back to the spacer, we'll go to the turbohaler, which also needs a strong flow dependency. And if we go to a turbohaler, one of the things that is interesting is if the turbohaler is loaded and the patient is not using it in an upright position, the powder does not enter the space that the patient will inhale. Now, the demonstration actually shows that this picture is demonstrating somebody not holding the turbohaler upright. And one of the commonest mistakes, and I watched my daughter make this mistake, is when they're having an asthma attack, they will hold the inhaler at 45 degrees because they urgently want the medication, and they click it, but they're actually inhaling no powder. They're only inhaling air. So one of the teaching methods is that you should put the inhaler on a flat surface when you actually click it. However, the diagrams that show you how to use it actually do not demonstrate this. And when you're having an asthma attack, to advise the patient to breathe out gently before using the turbohaler and put the lips around the mouthpiece and breathe in strongly and deeply. If you've watched how shallowly somebody having an asthma attack or somebody who's got severe emphysema, they cannot generate this sort of airflow. You then tell them to hold their breath for 5 to 10 seconds. Well, if you're having an asthma attack, that's going to be pretty difficult. And then that says, rinse your mouth out afterwards. So what I will show you a bit later is that the alpha inhaler or the alpenhaler, depending on how you want to pronounce it, actually requires a much lower airflow, and the drugs can be put in that. So one of the other things we are doing, and they are being printed at the moment, is an asthma action plan. Now, we will be supplying clinicians in the area, and we can quite easily roll it out to the region because we'll send you the soft copy and you can print it. But what we're doing in Zimbabwe is we are going to be giving primary care doctors and nurses that are trained an action plan that the patient can take. Now, if they're using a peak flow meter, we can put in the peak flow numbers. I'll go through that a little later. But basically, if you've got no symptoms and your peak flow is over 80% of expected, then you're in the green zone, and you as the doctor can write that they need to take their inhaled corticosteroids, for example, or a combination medication twice a day, and that's all they need to do, and use salbutamol or formoterol on an as-needed basis every 4 hours. When you enter the orange zone, which is where you have symptoms, maybe you've got a cold, you're waking up occasionally at night, there's a cough, there might be a wheeze, please bear in mind that the commonest symptom of asthma is cough, and children who have a chronic cough really should be assessed for asthma because you do not need to be wheezing to have asthma. But when you're in the orange zone, we will advise people to bump up their inhaled corticosteroid dose, and we might say that you need to use your reliever regularly every 4 hours. And when you're in the red zone, you can issue a script for prednisolone orally at 1 to 2 milligrams a kilo, and potentially an antibiotic if the sputum is colored. So this can be given to the patient, to be put on the fridge, and or put in laminated and put in an area and it gives control back to the mother, because mothers are very scared when children get respiratory distress. So this is another example. You can also put an emergency contact on that. So green is well controlled, orange is a flare-up, red is severe, and as mentioned, you can prescribe your prednisolone and your antibiotics with this. We're also going to be doing posters which will say what green means, what orange means, what red means, and this can also be printed on the back of the asthma action plan. So getting on to peak flow meters. A peak flow meter can be used as an alternative to spirometry, because I think there's only really 3 places in Harare where you can get spirometry done. And the important thing is the spirometry will go off about 3 days before the attack. So for athletes, for mothers, for patients who want to be in control of their asthma, you can give them a peak flow meter along with a spacer, and it can come in one pack. And you will get them to measure you can do a predicted peak flow based on the gender and the age and the height of the patient. And you can also get them to record their maximum peak flow. And if you are in the green zone, your peak flow will be 80 to 100% of expected. If you're in the yellow zone, it is 60 to 80% of expected. And if you're in the red zone, you are at 40 to 60% of expected. So our recommendations are you need to use the right device. If your patient is in a situation where financially they need to be careful, then probably salbutamol is the most affordable. But if they can use formoterol, they will be able to probably use it as a reliever and a preventer. So Symbicort have what they call the SMART plan, which is Symbicort maintenance and reliever therapy. We may call our plan the APART plan, which is Avacort, preventer and reliever therapy. So what you can do is, if you have a combination of formoterol with fluticasone, and if it's affordable, which it hopefully will be with the ALP inhaler, what you will be able to do is your patient will use it twice a day as a preventer, but they can also use the same device as a reliever. Now, just for some humor, I will show you, this is the ALP inhaler. I've put it on the group, on the SADC group, and I put it on the Intellectus Campus group. This is a video, and there will be a recording. You can press play. I don't think it is going to do the audio, but let me just try.
Sorry, Dr. J, when you select screen share, you also have to select share my computer sound. So you might have to stop share and share again.
Okay, stop share.
So share screen right at the bottom of your screen.
Yeah.
Yeah, to the far left, you select share computer sound and optimize video clip.
Okay. So share. Perfect. You see, this is why you control the technology and I don't. So let's
The ALP inhaler is a newly developed dry powder inhaler device The ELP inhaler is a device for the inhalation medicines delivered in a form of powder. Each dose is packed in a blister of a specially designed aluminum strip. The following are instructions to the patient for the use and handling of ELP inhaler. Open the storage case by pressing and take a strip. Uncover and push the mouthpiece backwards so as to reveal the drug supporting surface. Hold the blister strip with its shiny surface upwards so as to see the blue line, and place the whole of the strip around the attachment point of the supporting surface by applying light pressure. The blister strip will fit in the cavities of the supporting surface, and the guides will secure it in the correct position. A single or double cavity blister may be used depending on the drug delivered by ELP inhaler. Close the mouthpiece and pull away horizontally the embossed protruding end of the strip. The dose is now ready to be inhaled. Hold the device away from your mouth and exhale completely. Bring the ELP inhaler to your mouth and place your lips tightly around the mouthpiece. Breathe in slowly and deeply from your mouth until your lungs are full. Hold in your breath approximately 5 seconds or as long as you comfortably can, and at the same time remove the device from your mouth. Exhale and continue to breathe normally. After that, open the mouthpiece and verify the uptake of the dose. Finally, remove the empty strip. The ELP inhaler is ready for the next inhalation.
Okay, so I've used this device myself, and you don't need much of an airflow for it. It's a lot easier to use than the AccuHaler or the TurboHaler. And one of the other things that I found quite funny was one of my daughter's friends. I brought one home, and one of my daughter's friends said, "That's so cool, it looks just like a vape." And I said, "You should not be vaping if you're asthmatic." But anyway, that's another story. The teenage world at this stage still mystifies me. But one of the things that is important is that, you know, a child who is a teenager, who's self-conscious, who's an athlete, is not going to want to use a spacer and a metered dose inhaler in front of all their friends. So they'll often go into the toilet to use it. Whereas this is a much more subtle device. And as mentioned, formoterol works within 3 minutes. So for people who are athletes, this is a very good option, particularly if they're getting an attack when they are actually playing at halftime, if they have to come off, that sort of thing. So the asthma management plans will cover an MDI reliever with a spacer or an ELP inhaler. They will have a preventer. And one of the other things we will put into a pack is a peak flow diary with an asthma management plan. And if you see an asthma patient, you write out their plan, you give them a peak flow diary, you basically are empowering the patient and probably preventing a hospitalization. These asthma management plans were designed largely in Australia, where rural and remote communities may not have access to a hospital, and it may take 2 hours for an air ambulance to get to them. So that's the end of the presentation. I'm going to stop sharing now. And I'd like to open the floor to any questions. We have 9 minutes left for questions. So either raise your hand. Let me just see if I can get into the chat. Are there any questions in the chat?
Dr. Jackie, there is an earlier question. Just looking for it. There was an earlier question in the chat.
Okay, I've managed to get into it. As you know, technologically, so there's a question: what is the main difference between chronic obstructive pulmonary disease and asthma? So interestingly, the treatment is almost exactly the same, but asthma will come and go. You want me to stop my video? Okay. There we go. So asthma will tend to come and go. It will be intermittent, and obviously it's mild, moderate, or severe. So a mild asthmatic might have one attack a year, and they might always get asthma, especially if the trigger is pollen, you know, in the spring, or when they get a respiratory tract infection. Somebody with emphysema or chronic obstructive pulmonary disease has constant obstruction, and you will get them to do a peak flow. And for example, my peak flow sits at about 400, whereas I've got patients whose maximum peak flow is 120, and it's always like that. So asthma is intermittent. Chronic obstructive pulmonary disease is a permanent condition where the airway is damaged, usually by smoking. It may be by silicon exposure, so we will see it in the mining areas and in the mines. And they tend to require constant inhaled corticosteroids, so they need to be on a preventer all the time. The triggers may be the same, the triggers may be infective, and they tend not to respond so much to allergic conditions. One of the things I haven't mentioned, just because of time constraints, is that certain probiotics really improve the allergic side of asthma. And the reason for that is if there are if in the gut peptides can get through the gap junctions, they will cause an allergic reaction. So anybody who has a bit of irritable bowel disease or their microbiome is out, they may well react. Their airway may react to these peptides, these small peptide chains getting through. So Life produce a probiotic that is designed very specifically for asthmatics and people who get recurrent respiratory infections. So the main difference is that chronic obstructive pulmonary disease means you've always got obstruction, whereas asthmatics have intermittent obstruction. And it is possible, I've got another presentation which I won't go into because of time, that you can have both. Some people have chronic obstructive pulmonary disease, and on top of that, they will have allergic asthma. I hope that answers the question. Can you still hear me?
Sure. Thank you, Dr. Jackie. We have 2 additional questions on the chat. First question is, what is the onset of AVA-self and what's the recommended strength and age for kids?
So AVA-self is budesonide, and it is combined with salmeterol. So the normal dose is 250 micrograms of budesonide, and added to that is the salmeterol. But I do think that for kids, it makes sense to go for the Avacort, which is a combination of formoterol and fluticaside. And your starting dose for a child is 50 micrograms, and you can go up to 250 micrograms of the inhaled corticosteroid. And it will be coming in different strengths. But the way that I treat asthma, but it's how I was taught, I'm not sure there is always a right way, was to start with a higher dose. So probably go to 200 to 250 micrograms of Avacort and taper it back. And you can taper back quite quickly, but the objective is to get the asthma under control as quickly as possible. And then in one of the slides I showed you earlier, there's a step up and a step down approach. So equally, once you've got a child's asthma or an adult's asthma under control, you would then step down to the next level. And if it remains controlled, you step down again. And then if they flare, you step up. So the objective is to minimize the amount of inhaled corticosteroid delivered to the lungs, but to still keep the person in a situation where they can live a completely normal life.
Thank you for that, Dr. Jackie. We have another question from Toilifir. Is Alpenhaler available in South Africa, and is it affordable?
So I believe it will become available in South Africa. I think it is still going through the registration process. It is available in Zim at the moment. In terms of affordability, both Avasouth and Avacort are about a third of the price. So I know that Serotype here, people are paying like 80 to 100 US sometimes for the Accuhaler, whereas it's 37 US for the Alpenhaler, and that is for one of the higher doses. And again, Avacort will be about a third of the price of Symbicort.
Thank you. Thank you,
But
Dr.
I think South Africa is still to come onto the market.
Mm.
It's literally just cleared the airport in Zim. So this is pretty new, and it will only really be coming onto the pharmacy shelves, I would imagine, in the next couple of weeks. So there's another question about the role of interleukin antagonists in asthma. I've certainly seen patients do well taking a once-a-day leukotriene or interleukin agonist. And some patients do very well on it. One of the limitations of it in the Zimbabwean setting is the cost. We're still getting the branded versions of it. And in my own experience, I think the inhalers work better, but some kids will just turn around and not even need their inhalers. So it's worth a trial of using the interleukin antagonists, provided that the patient can afford it.
Thank you, Dr. Jackie. I think that wraps up the questions that are on the chat. If we can continue to invite, if we can please first request that colleagues and the greater membership and the audience to please remain muted, but please raise your hand so that we could acknowledge you before you make a submission. At the moment, we have concluded the questions and the comments that had been placed on the chat. We extend an invitation once more to the audience if they wish to make a comment or raise a question. We're a little after 7:30, we can continue to open up to the audience for another minute for any questions or comments. Dr. Jackie, at this point, if I can acknowledge you and extend gratitude for having led this session and delivered a stellar workshop this evening. Extended gratitude to you for having led us appropriately.
I'd also like to thank everyone. If you notice that one of my microphones is off, I'm in a situation at the moment. We had a bit of a techno panic about 10 minutes before, because I've had to open a second laptop because the microphone where the presentation was showing wasn't working. So I'm running the microphone of one computer and I'm running the presentation off another. So I would like to thank everybody on the technical side for guiding me through this and avoiding me having a panic attack instead of an asthma attack, because I couldn't get the technology to work.
Thank you. Thank you very much again, Dr. Jacke Stone. We wouldn't have a successful workshop without the audience, so acknowledge to the audience as well for having made the time to enjoy this session. A reminder before we exit the session, there is a link on the chat. You need to please complete the details or your details on that link. If you do not complete the details on the link, we will be unable to circulate your certificate. With respect to the certificate, our turnaround time for circulating certificates are at the moment approximately 48 hours. For anyone who hasn't received their certificates in the past, please notify ourselves so that we can furnish that. Alternatively, for those that have participated in the session, please look forward to receiving your certificates. This wraps up another weekly session of our CPD SADC region session. We will be running another session next week, Wednesday at 6:30 sharp. Please look out for communication within the WhatsApp group with regards to details and the link for the session. We bid you farewell for the remainder of this evening. A very good evening. Please feel free to exit once you've completed your attendance details. A very good evening to you all. A very good evening to our keynote speaker, Dr. Jacke Stone.
Thank you very much, everyone. And next week, I think, will be a very topical discussion. We're going to have a lawyer and a doctor on discussing artificial intelligence and who is liable. So I think it's very topical at the moment.